This evening, I'm delighted to say we're joined by my father, Dr. Peter Elton. A little introduction of him. I don't think it's filial bias to say that he's one of the most distinguished public health physicians in Britain, with an extremely long and full career. He was a director of public health for 18 years. He was for 2 terms on the UK's Joint Committee on Immunisation and Vaccination, and has been an examiner for the Faculty of Public Health Medicine, and is currently the clinical director for the clinical networks covering Greater Manchester and Eastern Cheshire, and has also been on a more informal basis advising the Labour Party on issues related to COVID, and for the brief time it existed, was the chair of the Vaccine Implementation Group for Greater Manchester, as well as publishing 40 academic papers over his career, and being very involved both on the academic and the practical side of public health medicine. He's going to speak this evening for about 20 minutes about COVID in general, the challenges brought by the Delta strain in particular, and then the vaccines, and then is very happy to take questions. So I shall hand it over to my father.
Okay, well, it's good to see everybody. Thank you very much for inviting me. So I'm going to just say for starters that I'm going to assume that everybody agrees that COVID is a serious illness which has serious repercussions for everybody. There are still people on social media who thinks it's a hoax and that it's just another respiratory infection which we shouldn't take too seriously. If there's anybody in the on the Zoom who thinks that, I'll let them ask that question when we get to questions and answers, but I won't deal with that now. I'm going to first talk about the COVID crisis in general, and then I'm going to talk much more about the vaccination and comparing a bit about the UK and Australia. The important thing to say is, how have countries been dealing with the COVID pandemic? And people have been coping very differently, and you see very different performances. This is a mixed audience, but I have to say that it has been pointed out that countries that have done better have generally had women as their prime minister, or whatever their leaders are called. So you got New Zealand, Taiwan, Singapore, Finland, and various others. There are a couple led by women who seem to do very well at the beginning and perhaps done less well as time's gone on, such as Germany and Bangladesh. But again, I think it's not women, it's more of a deeper issue. So people have pointed out mistakes and just compared the mistakes that people have made in terms of isolation, track and trace, and whatever. But I think that it's a much deeper mistake that people have made or have done correctly. And I will illustrate this a bit comparing Britain and Australia and New Zealand. The 2 important characteristics, I think, that have got the UK into trouble is, one, a complete lack of honesty. So that's probably not just Boris Johnson. Boris Johnson is not known for his fidelity to the truth. And I just will give, there's lots of examples, but I'll just give one example. So when the COVID crisis first started, we didn't have enough tests to do track and trace properly, to test everybody who came in through the airports. And so instead of admitting that, they pretended that it wasn't necessary to test everybody who came into the airport. And in fact, the Deputy Chief Medical Officer, when they said the World Health Organization said test, test, and test again, she said the hints in the word world, and we're not like the rest of the world. And it doesn't do anything to test people, which was clearly nonsense. if they'd been honest and they had admitted they didn't have enough tests, they would have taken an alternative strategy. So if you didn't have enough tests, you then needed to lock down much earlier, and it would have led to a much better conclusion. The second thing is about being open to people giving you advice. And Ben was in the civil service, so he'll very much know the culture that he worked for somebody who was very open. But in generally, people who are not at the top feel it difficult sometimes. The minister or whatever makes it clear what they want to hear, and it's very difficult to challenge that. So we had lots of examples when practically everybody knew the right thing to do, but for some reason there wasn't sufficient challenge in the system. And perhaps the latest example of that was now about 3 months ago, when it was patently clear that India was suffering very badly, that we should have been stopped people coming in from India, but Boris Johnson was going to do a trade deal in India and still wanted to be able to go. So they delayed for about 2 weeks introducing the ban from India. And then they did the most stupid thing of all, having announced they're going to ban people from India, they delayed for 4 days for introducing it. So not only did we have 4 days of lots of people coming back from India importing the virus, we had extra flights put on, so even more people could come back. And if they listened to the advice, they would have never have done that. I should just add one other thing about a general characteristic. So Trump, Bolsonaro, and Johnson are all ideologues who sort of believe in personal freedom, that that there's a limit to what society can do, etc. And if we will all have our different views, come from different parts of the political spectrum, but the one thing we can be absolutely sure that when you're dealing with the pandemic, you've got to deal with it as a society. And it's quite clear, for example, that Australia's dealt with it as a society. So I said about it being mainly women, so there isn't a question about men. I know you've got a woman prime minister in New South Wales, but not in Australia as a whole. And Ben indicated to me one crucial difference in Australia and the rest of the world, and that is that you have compulsory voting, which means that instead of, you have to try and appeal to a majority of everybody rather than your base. So the people I mentioned, like Trump and Johnson, they're never going to get more than 50% of the vote. So they appeal to their base because turnout is very important. That's less of a consideration in Australia. So I know you have rather rumbustious politics, but it makes to a more consensual policy making, which has probably stood you in good stead. So I know Australia made some mistakes, like letting the cruise ship into Sydney Harbour early on, and in Melbourne having insufficiently trained quarantine officers in your quarantine hostels. But generally, even when you made mistakes, you've recovered very quickly and prepared to make the hard decisions, such as what I know you're going through now. So that's a general background about COVID, and I'm happy when we come to questions to answer that, but I'll move on to the vaccination. So there's been, so I'll talk about vaccination in general, but I know that a burning question is about what vaccination to use. And I'll come back to that in more detail in a minute, but I did want to say before that, the one thing we need to remember is that in last autumn, when we were waiting for the vaccines to arrive, the general consensus was that if we had a vaccine that was 50% effective, we would be very happy. That 50% was sort of the threshold for what we thought was worthwhile. And then it turned out that it was much, much higher. So any difference we talk about is way above the threshold that we originally thought. And there does seem to be differences between the two vaccines in terms of efficacy. Pfizer seems to be slightly more than AstraZeneca, but the difference is relatively small, particularly after you've had 2 doses. And the the other thing is about the side effects. So, about 4 in a million people die after having the AstraZeneca jab. And that's a sort of risk we often accept for lots of other things. So for the older members on the call, there used to be more than, that used to be a higher risk than that when you went on a plane many years ago, and yet many people accepted that risk. And we certainly accept risk when we go in a car, etc. The risk has probably come down because we now know what is causing those deaths, and the treatment has improved. So that's a big difference. So what I would say to people is, if I had an absolutely free choice, and I know you've got Pfizer and AstraZeneca, I would go for Pfizer. But if I didn't have a choice, I'd be very happy to take the AstraZeneca. I much prefer to have the AstraZeneca than nothing at all. There's a big issue about prioritization of who gets the vaccination. So it's very interesting that practically everywhere in the world has gone from for basically an individual policy. So they've been giving prioritization to the highest risk people, which is very strange in a pandemic, because the way to protect the population is to get as much interruption of the transmission as possible. So they did a bit of that everywhere, really, by vaccinating healthcare workers, which seem to be around the world. And Australia's gone further than other places. So you're doing blue light workers as well. And you're also doing people who work on quarantine. And that makes absolutely sense to try and create a firewall. The big difference actually in Australia is that you've taken very seriously the evidence that meat processing workers seem to be at particularly high risk of COVID, and they were in your highest risk groups. But it's strange, particularly in Australia, where people weren't at much individual risk at the moment because of the low level of cases, that you've been giving priority to old people, particularly very old people, rather than people who will spread the disease if it actually gets in. So I'm afraid I've made virtually no progress whatsoever in trying to influence people. But we should have been, and you should be immunizing taxi drivers, public transport workers, restaurants, people working in restaurants, security guards, which I don't think covers any blue light workers. You should be giving your first priority to all the people who are likely to transmit the disease, and then work on the elderly people. I mean, we had in Britain the absurd situation where restaurant managers were the highest risk group with 10 times or more of the risk of getting COVID. And we weren't vaccinating them while we were vaccinating people of 100 years old with dementia. And, I think we should save people 100-year-olds with dementia when we can, but when there's priority, I think it's clear in my view where that priority should have been. It was partly in Britain as a result of having messed up our care homes and discharging lots of people from hospital into care homes and spreading disease that way, that there was too much political pressure. But it would be much more sense to have had a community approach. So the other issue is the length of time between the doses. So it was quite clear from the first studies done on the AstraZeneca that having having more than 12 weeks between the having more than 6 weeks between the doses and 12 weeks, that you got much better protection. It was a stretch extrapolation to say that for Pfizer as well, but immunity tends to work in the same way. So it does look as though you get greater protection the longer there is between the doses. So I say in Britain it's slightly different because you do get much more protection after 2 doses. So when you've got a surge, you're trying to get as many people having 2 doses as possible. But where you've got very few cases, and even with your lockdown, you've got very few cases, what you want to do is to create as much immunity in the long term as you can. So I would say, both as a general policy, Australia should be having 12 weeks between the doses. So that's what I would say. And I would say further that in Australia, because you get, with the vaccination, you get probably a reduction to a third, by 2/3 reduction with 2 doses and 1/3 reduction with 1 dose, that you should do as many first doses as you can before doing any second doses, with the exception of those who are likely, who could get COVID more easily. So quarantine workers should absolutely get the second dose without delay. So the issue of doses, I think, is slightly different in Australia from the UK, because we've reduced it now to 8 weeks, and they're talking about reducing it to 4 weeks. And I really think you ought to do that. And I would say that if by doing all first doses, your second dose is when the vaccine to the variant becomes available, that will be even better. Because there's no doubt, even against the Indian variant, the second dose increases protection, that the biggest protection will be if your second dose can actually be against the variant. So with 2 doses, it looks as though you get about 2/3 or even 4/5 reduction in cases, and in hospitalization you get about 90% reduction, and in deaths you get somewhere between 95 and 98%. So last week, for example, there'd been 118 deaths in people who had 2 vaccinations. So we've got a population of 60 million, so the risk is still low, but it's not non-existent. It probably is also dependent upon the dose level you get. So the 2 things combined, if you don't expose yourself to people too much by face-to-face contact, and you've got 2 doses, you are pretty safe. So the last thing I wanted to say is just something that you probably haven't heard anywhere else. So this might be particularly interesting. The AstraZeneca, when they did the trials, they found that half dose followed by full dose worked better than 2 full doses. They then looked at the data again and said that was mainly due to the longer period between the doses. The trials were mainly under 55, so they're worried in older people that if you gave a lower dose, you might not stimulate the immune system sufficiently. But for younger people, you could have given half doses. And when we've got a world shortage of vaccine, I would strongly advocate that we use half doses. And in fact, with the Pfizer drug, there was a study in Nature which showed that although there was a bit of a dose relationship in terms of antibodies, you still got a good antibody response with 1/30 of the dose that was given. So the way the Pfizer works, you could probably get 15 doses out of a vial rather than 6. And again, for Australia, you're going to get protected by everybody else getting vaccinated. So the less you can use, the less we can all use in terms of vaccine, the more we can give it to other countries, the more important. I've raised it, but 1 or 2 other people raised it, but it's had virtually no debating time about using lower doses. There's a problem because it's not licensed for lower doses, but it seems to me that when we've got a pandemic, we've got to do what is best for everybody. So I've just taken over 20 minutes. There's a lot more I could say, but I think it's, we agreed I speak for 20 minutes and then we would have questions and answers.
Thank you very, very much. Before we turn to the questions in the chat, could I just ask a question about children and how children might be transmitting, particularly the Delta variant?
Yeah, so that allows me to say 2 things. The first thing is that the Delta variant looks as though it's twice as transmissible as the original variant. So in Britain, we've got just over half the population vaccinated. So our percentage is given of the adult population, but if you include children, that's just over half. So if you take that, but the variant is now double the transmission rate of the original virus, we're really back to square one in terms of protection against transmission. We're slightly better, but not a lot better, and that is why our cases are zooming upwards. And of course, one of the reasons why we've got a large part of the population unvaccinated is because we haven't approved in this country, have in other countries like Israel and America, we haven't approved vaccination against children. So I think particularly for 12 to 18-year-olds, which is what's been done in other countries and who seem to transmit the virus more than children of primary school age, is absolutely vital. But again, going to the level of doses, I think it's really, people have said, is it moral for us to be vaccinating children who've got very low risk? Although if you look at Mississippi, they've got, I think, 10 children in intensive care with COVID. But they say, is it moral to vaccinate children who've got very low risk when there's other countries who can't get hold of the vaccine? And so I think we do need to conserve it. So I think we should definitely be vaccinating 12 to 18-year-olds, but with half doses or less, because what you may be doing is to stop transmissibility rather than to protect them themselves.
And do you think that children of, let's say, below 5 or 6 are a worry in terms of transmitting the disease?
So I think they do transmit the disease, not as much. There are studies going on looking at younger children, and I'm pretty sure we need to go down probably to 2 years old in time. But the risk to children seems to go down even within the age range of children. The younger you are, the less risk there is. I should mention something else about children, and it might be to do with, so the common cold is caused by another coronavirus. And there was this thing that that school teachers, who you might expect to be in very high risk of COVID, weren't actually getting it that highly. So it was about average. So it was more than the very low risk, but it wasn't as high as you expect. And it's thought because teachers were exposed to a lot of the common cold, it was giving a little bit of protection against COVID as another coronavirus. There's a bit of cross immunity going on there. So that might be why young children are not such a great danger, but they definitely do it. If we want to add to community immunity and avoid transmission, we need to go down to as younger age group as we have evidence.
So just turning to the questions in the chat, the first one from Marilyn Chalmers, it talks about asking a question about the side effects of Johnson & Johnson. Guillaume Barr.
Yes, so there have been side effects, and there seem to be more against that than some of the others. They still seem to be low. So if it was the only vaccine that was available, then we should be using it. There's something very strange with that vaccine. So what they've done is they've said it's a one-dose course. And the trials all show that, and they show the level of immunity, but the efficacy of one dose of that vaccine seems to be similar to the efficacy of one dose of Pfizer and AstraZeneca. So the only reason why it's a one-dose course is because that's all they've trialed, not because it's any better at one dose than any of the other vaccines.
There's a series of questions about a third dose or a booster vaccine or mixing vaccines, so having AZ or Pfizer to begin with and then using the other one for a third dose. What are your thoughts? What's the evidence about third or booster doses?
So on booster doses, as you know, there's a row going on in America where the FDA are not liking Pfizer pushing for a third booster dose. So I think there's a number of issues. I think, first of all, the booster dose, there seems to be little doubt that increases immunity more, particularly perhaps after 6 to 12 months when some people, particularly older people, their immunity may be waning. I think even developed world, our protection will both come from protection of what we give to our own population and the level of immunization in the rest of the world. So the issue is, are we better giving a booster dose to our own population are giving those doses away to poorer countries who will import it to our countries. And my feeling, I haven't seen all the data and all the modeling, but my feeling is that we're better off giving it away to other countries and waiting till we have the dose against variants. So that's not to say the booster doesn't work. It's just about taking everything into account. There's another question you're asking about that, Ben. So that was the booster dose and...
I think that answers the two questions I had. There's more questions coming in. I'll group them together. Somebody's asked about myocarditis with Pfizer and whether Novavax might be a better bet. That's one question. And second, if you have the Johnson vaccination, should you seek to have AstraZeneca or Pfizer in addition to it?
Yeah, that was the other question about mixing it. So I looked at the evidence, and because Pfizer is generally a bit more effective than AstraZeneca, it did look as though it's worthwhile switching from Pfizer to AstraZeneca for your second dose or your booster dose, but the other way around didn't seem to me to be particularly worthwhile. It wasn't so much changing; it was actually using the more effective, and you don't lose anything from changing to Pfizer. As far as myocarditis is concerned, it's rare. It's also an effect of the COVID itself, but it's rare as well. So again, I think overall, in terms of the total efficacy and the total side effects, if you have a choice, I still think Pfizer is the best, but not so much better, as I say, that you do it in the absence of anything else.
Just to follow up on that, as I understand it, AstraZeneca and Pfizer use two totally different technologies.
Yeah, so Pfizer uses a bit of RNA, and which means it's much quicker to produce, much quicker to change. AstraZeneca is attached to a harmless virus, which is the more traditional technology.
And even though they're different technologies, you can still mix them.
Oh yeah, yes, because they both stimulate the immune system. One thing I could have said earlier was that the reason why Oxford got up and running so quickly was that they spent years preparing for pandemics, so they could generate a vaccine. It was very interesting because we also were planning for the pandemic in other ways, like we had Operation Cygnus in CYNGUS in the UK, and it was done 2016, and that still hasn't been published. So when we're giving out accolades and brickbats, it seems to me the vaccine community have really come up trumps.
A more political pair of questions. Why is England coming out of lockdown when there are so many cases? And what will the results be of that, I suppose, in terms of cases and of deaths? And there's some pressure here in Sydney, in New South Wales, for the lockdown to become even stricter as the only way to stamp out our cases, which were 100 cases today. What are your thoughts on those?
So on the UK, it's because if you've got an ideological fix that that is people's responsibility, that we don't act as society, you're forever pushing to end the lockdown, and regardless of whether it makes any sort of sense. So the overwhelming view of the clinical community is that this further easing of the lockdown when cases are shooting up is absolutely ridiculous. So one of the problems is they say it's weakened the link with hospitalization and deaths. That's true, but it may be that we're going to have 3 or 4 times the number of cases than we had at our previous peak, and hospitalization is reduced by 3/4, it looks like. so when I say that's not the individual reduction, that's reduction in society. So that's a mixture of the reduction of, the reason why it's not 90% is because you've also got the people who are unvaccinated. So it looks as though we're going to have lots of hospitalization. I have seen models which indicate that we're going to have doubling of COVID cases every 2 weeks for the next 6 weeks. And then it's suddenly going to go up exponentially, and then it's suddenly going to go down exponentially. And the modeling say they show that. I think it's on the basis of increased vaccination and increased people getting the immunization. It just doesn't seem credible to me that it will suddenly reverse so suddenly. And I'm pretty sure we're going to have a further lockdown in this country, because the hospitals, I think, are going to be overrun yet again in our country. And I think, it's what I was saying before about not listening properly to people. As far as Sydney's concerned, so one of the successes of Sydney and Singapore and Taiwan is a very good track and tracing system. And I think that was the right policy. It still is the right policy. But when it started, we had a much less transmissible virus. And I think the only reason why you've got half a chance at succeeding is because you've had over a year of finding out how to do track and trace best. You've learned lots of lessons. The Indian, as I said earlier, the Indian variant is twice as transmissible as the original variant. I think that if we started off with the Indian variant, I suspect that none of the places who've done track and trace and who were at the starting place of doing that. It's true in Taiwan and Singapore, they'd had experience of doing track and trace with previous viruses, but I still don't think they had the level of experience they've had now. And I think you would have a chance. It looks as though you've got a very finely run system. You seem to have stopped cases going up, but reducing them is going to be a big challenge. And I think you may have a choice between having a even stricter lockdown for say 2 or 3 weeks, or a longer lockdown for say 2 or 3 months. So I think you've got a choice, and I think you're probably doing enough to get it under control with the present lockdown, but it will take longer than doing a very strict lockdown.
Do you have any thoughts about the Novavax vaccine?
Yeah, so it looks as though it's not quite as effective as the others. It might be only 50%, which, as I said originally, if we'd had, would have passed the test when we originally had the vaccine. But because we've now got vaccines that are even more effective, I would be so I think in countries that haven't got anything else, they should use the Sinovac vaccine. And I think as well, because we know that mixing vaccines seems to work, if other vaccines become available, you can give second or booster doses with other vaccines, but at least get some. Sinovac definitely seems to give some protection, but some people have indicated it might even be less than 50%. But certainly, if that's your only choice, you certainly ought to use it.
I want to invite other people to submit questions. We're getting through them quite quickly. My father's very businesslike about these things. What do you think is the long-term picture or the medium-term picture when societies get to a state of over 80% with two doses? What's the situation look like in terms of how we live with the vaccine?
Yeah, so people say we need to live with coronavirus. I think I think people actually mean we need to live and we need to die with coronavirus, because I think you'll still get some deaths. I think the big thing about, one thing that I haven't spoken about is the difference between flu and COVID. So some people have said that COVID is just like a bad bout of flu. So I want to point out some big differences between the two. One, the R rate is the number of people the average person infects. So the R rate for flu is much lower than for COVID. And that's why it probably dies out much quicker every winter. the other thing you've got to remember about COVID is that we have long COVID. So it does seem vaccination protects against long COVID, but if people haven't been vaccinated, about 5% of people get long COVID, 5–10% of people. And we would expect still a proportion to get that when they've been vaccinated. So I think it all depends upon the variants. So I think it's not about 80% vaccination in every country. If we have 80 in only one country, it's 80% vaccination across the world. So if we get to that stage, we might get down to low levels of coronavirus, and that'd be fine, because not only will it mean there's not so much around, the chances of having a new variant will diminish considerably. So I think at that stage we'll probably be all right. It does give me a chance to talk about how mutations occur. So before the vaccination, the biggest evolutionary pressure on the virus was on those that are more transmissible. So the more transmissible it is, the more it's favored. I think that's for obvious reasons, but if anyone's not sure, I can go back to that again. At that stage, the thing that often happens is you get milder variants, because the last thing a virus wants to do is to kill its host, because it kills its host, it kills and it can't spread. Both the good and the bad about coronavirus is that even at its worst, it killed 1 to 2% of the population. So that doesn't give much evolutionary pressure to create less dangerous variants. I mean, it will over time, because it pushes a bit in that direction. And even if it doesn't kill people, if it makes people very ill very quickly, that leads to milder variants, because obviously if you're debilitated and you're stuck in your bed, you're less likely to spread it. So one of the reasons why coronavirus is so effective is that a lot of people don't get it seriously, some even asymptomatically, and they can be around and spread. If we all got it really badly, it would have probably died out very quickly. So it doesn't create that pressure. The third evolutionary pressure is with the vaccine. So when you have high vaccination rates and high level of cases, and we're actually producing that absolute mixture in the UK, that is going to favor mutations that aren't the vaccines aren't effective against it. So it's been said that we've got a variant factory in the UK by having this really potent mixture. So at the moment we have more cases in Britain, in the UK, than we had when the Alpha variant, which was from Kent, the first variant that caused problems. We have now more cases per day than we did in the original thing. So I think that is a real danger. If we don't get under control in the whole world, we're going to keep on getting variants, and we're going to keep on having new vaccines to be produced. And it's only if we get good vaccine coverage all over the world and really dampen down and we can't do it by just having lockdown all the time. It's going to have to be through the vaccine, but it's going to have to be worldwide. There was a question about Israel.
So I'll give you three more questions, see if you can jump through them. One is the origin. What are the best thoughts about the origin of this virus, the leak or the pangolins? The second question is about zinc or copper impregnated masks as they're using in Israel. And the third issue being raised is what are the chances of getting COVID or getting sick from COVID after being fully vaccinated?
Right. So the first one is that there have been these theories about it coming from the labs in Wuhan. I think what we've learned down the years is the most likely explanation turns out to be what usually occurs. So it requires a lot of very odd things for it to have occurred from the laboratory. And I think it's almost certainly come from the wet market. I mean, it doesn't let the Chinese off the hook, because their habits were disgusting. But you know, well, to Westernize, they're disgusting anyway. mixing live animals with dead animals in small cages. And the Chinese had said years ago they were going to stop doing it, but they didn't. So I think when I was trained as a doctor, I was always taught common is common. Always go for what is the common explanation. So it's not impossible it came from a laboratory. It just seems most unlikely. I know absolutely nothing about zinc and copper from Mars, so I'm not going to pretend to answer that question. Sorry about that, Jake. And the third question was, about 2 doses. Yeah, so 2 doses, as I say, you get, reduce the chance of getting it by 2/3. What I didn't mention was that even if you get the virus, your chance of passing it on to somebody else is halved as well. So your transmission risk is much lower as well. With the 118 people who've died in UK after 2 doses, we'll have more now. We haven't got enough data about how many of those are frail, etc. We know that only 2 were young. So undoubtedly, it's going to be the usual risk factors. So if you're immunosuppressed, you might still want to be very wary, even if you've had 2 doses.
In terms of international sort of medical governance, are institutions like the World Health Organization and similar bodies, are they now better prepared for pandemics? Are there lessons been learned? And an associated question, are pandemics more likely in the future than, will we have to wait another 100 years, or are they going to come sooner?
As far as the World Health Organization, if you look at the track record of the World Health Organization in this pandemic, it's not been bad. Most of the advice they've given, if governments had taken all their advice when it was given, we would have done very well. And for example, the World Health Organization at the moment is saying that the UK need to be very careful what they're doing. The problem is that countries don't always listen to what the World Health Organization say. So I'm not saying their track record's been perfect, but actually, if everybody had followed exactly what they were doing, it would have been fine. The second thing is, sorry, I've got. Oh right, I've been given a glass of water. Thank you very much. Sorry, the second question, I've been distracted by that. Go on. What was the second question?
If people had followed the advice of the World Health Organization,
No, but you asked the second question after the World Health Organization.
Oh, yes. When's the next pandemic coming?
Oh, yes. So, well, of course, we've had a lot of pandemics. We had the swine flu, we had SARS, and we've had various other ones. I think we've had previous flu pandemics as well, in 1957, for example. I think that as I said before, what was particular about coronavirus, which has been particularly unusual, it's a disease that has a low mortality rate of 1-2%. I know that's shocking in terms of the total number. It has a low mortality rate, high transmissibility, and therefore can spread. Of course, international travel and all other things will increase it, so we're probably more vulnerable to that. But I'm not sure the chances of a particular combination of being mild in most people, but being deadly in a small number is likely to repeat itself very often. So it's a chance. So I think we will get pandemics, but I think most pandemics will either be completely mild. I mean, swine flu was relatively mild, it didn't cause many deaths and died out, or it will be so severe like SARS that you have to do things to try and dampen it down quickly, and MERS to dampen those down quickly, but they're relatively easy to dampen down because people get taken out of the system fairly quickly when they contract the virus.
In terms of international travel, what's your view of travel? And in particular, I think this person has a specific interest, travel from Israel to Manchester.
So I think So there's a general issue about travel. So there is about spreading it from one country to another. But I think that's probably not the major problem. I think the problem about travel is people go on holiday. And when people go on holiday, they like to drink, they like to go into bars, they travel a lot. You have a lot more mixing. So even when UK people go to Spanish resorts, it's not getting it from Spanish, they might get it from Spanish people, but it's not that, it's getting from English people that they have, or UK people that they're having close contact. So I think that's a problem about travel. It leads to more mixing than you would normally have.
You're not, not particularly concerned by planes, for example?
Oh, actually, planes seem to be particularly safe. We have a professor in Manchester who particularly looked at this, and because you've got to have a certain, you might not guess it because the people get headaches in planes, but because you've got to have a certain amount of air exchange in planes, he said one of the safest places you can be is in a plane. I'm not sure the airports are so safe. So one of the problems is we've now got more paper filling, and you've got to show your PCR check in when you get to the airport. So in the UK, we've got these greater checks, but as a result of that, we've got longer queues. So people are going to be stuck in buildings with many more people as a result of that. And I think that might be very dangerous.
In terms of masks, do you think the masks being used at the moment are enough, or we need to have higher grade masks?
So I think in hospital, there's very good evidence you ought to have higher grade masks. So you've got to remember that people in hospital are dealing with COVID patients. They're often exposed to very high levels because people are ill, will be coughing and whatever. So the extra protection you get from higher grade masks is really important. For the general population, of course, if you have high grade masks, you get more protection, you'll protect other people more, but actually we'll get most of the advantage by just wearing masks. The real danger is not using masks at all.
Good. I think we've worked our way through most of the questions. I just give a minute or two or a few seconds for people to add any questions into the chat. Last chances. A question about rapid tests.
Yes.
What do you think about the efficacy of rapid tests or saliva-based tests as opposed to going in and having a probe stuffed up your nose?
So the issue. So this is the issue between the PCR test, which you go to a place to have done, and the lateral flow test, which you do yourself. So there's a couple of things about that. The lateral flow tests do seem to be better when done by a professional. So they have reduced effectiveness when you do it yourself. But the big thing is that what we're saying is particularly when you're isolated because you've got a contact, you should be doing the lateral flow test every day. So the sensitivity, the proportion it picks up on one single test may be only 2/3, but if you do it every day, the sensitivity builds up. So if you've done it for 4 or 5 days, it will pick up probably 90% plus of the people with it. So I think it's a very important thing to do. So I think to use lateral flow tests it's probably better than nothing as a test of whether you can go into a nightclub or perhaps a sporting event is of limited use. It may reduce infections a bit, so I wouldn't be against using it. But the idea that if you got a negative, you are safe to be near somebody else, I think is not sensible. And when we had the England-Scotland match in the European Cup, out of 12,000 people who attended Wembley from Scotland, 397 got COVID within 2 weeks of attending that match. So they might not have all got it at the match, they might have got it when they were in the coaches together, etc. But clearly, and they all had to have lateral flow tests. So it clearly didn't work very well. And I think that's a problem, but doing that. Should pregnant women have, sorry, go on.
Yes, pregnant women and the vaccine. or nursing women the vaccine?
Absolutely, pregnant women should have the vaccine. So the risk of stillbirth and preterm birth is twice as high if you've had COVID. So, we're talking about starting with a low risk and it's doubling of a low risk. But there's no evidence that there's, except for in the usual rate we've talked about in terms of blood clots, etc., 4 per million dying as in the initial group. There's no extra risk in terms of pregnant women. So the proportionate risk increases because pregnant women do have a slightly increased risk of clots from just being pregnant. But absolutely, the risk of not having it is much greater than the risk of having it. All these things change in Australia. So, certainly if you got anybody, it says my wife works in maternity ward, anybody working in hospital should absolutely definitely get it, because even in Australia, you've had people admitted to hospital with COVID. So that's a high risk situation. In the UK, I would say any pregnant woman said, I should say, have it today. In Australia, when there's less vaccine, when there's around, I might not give the highest priority to pregnant women and have it when I got over the pregnancy. But if the cases ever went up, I'd want to have it immediately.
I'll ask a question which is very close to my heart. How would you, if you were asked to advise a shul, how would you make a shul service, particularly a long shul service like Rosh Hashanah, how would you make that safe?
I should say that I've been advising some of our local shuls about this. So I think ventilation is very important. So I'm talking in general because I know you've got certain problems at the Great, but certainly the number of air exchanges is important. Social distance is important. Masks. I think you shouldn't be sharing taluses and sidorim. I think that's probably less of a risk. I think the transmission from surfaces is probably one of the least important ways of it transmitting, but it's just sensible to do. And I would say have breaks. I know it's not what normally done, and again in the Great it's difficult when people just can't pop home for a few minutes, but to have, for example, on Yom Kippur, if you're allowed to open for Yom Kippur, I think probably if there are cases around, so this all depends upon whether there's cases around, you're allowed to open. So in Australia, that might not happen. But if you did have cases around like we had here, I would say you must break at least every 2 hours and give the shul at least half an hour to clear, to allow the virus to escape and open all the doors. You're on mute, Ben.
We'll end with this question. Looking to the future, when do you think the world will have full control of the virus and we won't consider it a problem anymore?
So I think the reason why that's difficult to answer is the hope is, for the reasons I gave, that we will start to get variants which will be bound to be more transmissible, because that's they're bound to be more successful, but are less dangerous. So if we get and that's what usually happens to viruses over time. You get less dangerous variants. So I think in that time we need to protect ourselves with immunization. They've talked about the whole world being immunized by 2022. I suspect because that means some people will be some time since they've had their 2 jabs that will probably need to have a booster. So that might be 2023. But by 2023, hopefully the whole world will have had a reasonable amount of immunization. Depends upon whether in some countries we have so much vaccine hesitancy that we don't get to herd immunity. But if we do, that will be fine. And it will still spread for the reasons I've said. And then what you hope is that there will be less virulent strains, and we will have some we call it booster doses, but I'd rather say it's new dose, because it's a bit like the flu vaccine when you have it each year, but it's against different strains. We'll have new COVID vaccines which are against the new variants, and that's what will work.
Well, thank you very, very much. I'm very grateful. Fascinating and so detailed, and so much a finger on all the details across the board. Glad everyone got to meet my father, which is also a great pleasure. Please God, he and my mother will be back in Sydney in the next couple of years, and you can meet them in person. I saw we had up to 100 people on the call tonight, which is fantastic. I'm glad it was so popular and well received, and wish everyone a good night and continued health and safety. And as I always say, I'm here, and Rabbi Phil is here, and the shul is here if you need anything from us. So a good night and God bless.